Oh, me. I can't. Okay, thank you. Kathleen, do you want to tell them about what's coming up next month real
Sure.
quick? And then I'll get into it.
Absolutely. Our next Gray Anatomy course is on health advocacy. And we're excited that Jill Ice, who's a community educator for the Care Partner Project, will be with us for that hour. And she will share some practical information about how to partner with doctors and nurses to get the best healthcare possible for yourself. We've heard rave reviews about Jill's ability in the community. She's really helped a lot of people, and we're very, very excited to have her join us. The date for that is on Thursday, June 30th at 4 o'clock. And you can sign up through the library website at lplks.org/retirement. And so we hope that you will join us. And that actually will be our last Gray Anatomy course for the summer. We're going to take a couple months off and regroup and bring you a whole new set of topics starting in September. So with that, now I will definitely turn it over to Kathy.
Okay, thank you. Hi, everybody. I'm Kathy Hamilton, and I will be sort of moderating our discussion today. I don't know if Kathleen said you might want to watch this on the screen view as opposed to the gallery view, so you can see the doctor and his slides as big as your screen. But otherwise, I will just go ahead and introduce the doctor. Oh, and we will do this a little bit differently question-wise this time. Go ahead and put your questions in the chat as they come up, but we will be waiting for the end of the presentation to ask them to the doctor. Kathleen is going to be working his slides for him because he's on an iPad, so that we just thought it might go a little more smoothly that way. So I'd like to introduce you to Dr. Cleve Pilakowski from Lawrence Podiatry. And Dr. Pilakowski has been here for 9.5 years. Before that, he practiced in North Carolina, although he assures me that he is no Tar Heels fan, and in fact had KU on his bracket more often than not, North Carolina. So knowing that, I will just tell you his wife's name is Lori. So when you look at his screen there, you just know that that is Lori's computer, iPad. She is also the office manager as well as the doctor's wife. So thank you so much for joining us, doctor. And you can just go right ahead. Tell us about our feet.
All right. Like I said, I'm Dr. Cleve Pilakowski with the Lawrence Podiatry Center. We're here in Lawrence, Kansas, and we're just going to talk about your aging feet and go through just some brief things and then answer questions here at the end. If we can go to the next slide there. Just briefly about a podiatry or a podiatrist. A podiatrist is someone who specializes in the foot and ankle. We attend the podiatric college instead of, we start off in podiatry right away rather than specialize after medical school. So we do podiatry school right after college, and then anywhere between 1 and 4 years of postgraduate residency. Basically, we do everything with the foot and ankle, skin, bones, nerves, really everything to do with it. And, we do surgery in the office, at the hospital, a little bit of everything as far as, taking total care of the foot and ankle. Next slide, please. Basically, a goal of a podiatrist, or, me especially, number one, I want to keep people as active as they can be for as long as we can. As we go through life, we definitely want you to do what you want to do. And by keeping your feet good and healthy, that makes it a lot easier. Also, of course, we want to prevent future issues. And by having good, healthy feet, that can make a difference to allow you to stay more active as we go through life. Next slide. Some basic signs of aging feet. This happens to everyone as we go through life. Number one, less flexibility our joints don't move quite as well. They're a little bit more stiff. The skin and fat pad diminish as we go through life. You'll notice that you're more prone to little breaks in your skin. You find that bare feet, especially on those hardwood floors and tile floors, are not friendly to you anymore. Just your basic wear and tear. Your joints don't work as well. You can't stand up as long as you used to and do what you wanted to do before. Typically, as we age, our feet also become colder. That's why you will find that, a lot of people love those socks on at night, or find that their feet really do get colder. And that's not unusual at all as we go through life. Of course, arthritis, it affects all over the body, and the foot is definitely not, away from that either. Everyone usually gets some sort of arthritis in their feet. It's just a matter of how much it affects your daily life. Another thing is you're more prone to fungal infections. The athlete's foot, or that darn onychomycosis, that fungus that gets in toenails. You'd be shocked at how many people end up with fungus in their nails. More have it than don't, as we age. Next slide. So like I'd mentioned, the conditions we treat, we treat everything. Dermatologic, such as skin and nails; orthopedic, bones and joints; neurologic, nerves; and of course, a lot of diabetes-related foot and ankle ailments. Next slide. So we sort of skipped the dermatologic one there. Can we go back to that dermatologic conditions?
Yeah, I think she's working on it.
Oh,
She's
okay.
muted, so
Gotcha.
there
we go. So skin conditions. Number one is onychomycosis. Onychomycosis is that fungus infection that gets into our toenails. Typically, they'll become thick, discolored. They can become very painful. A paronychia is basically an infection of the nail region, usually caused by like an ingrown toenail or an injury. A verruca is it's a wart, which you can get warts on the feet. Tinea of course, is athlete's foot. Once again, these are all common things that we see in the skin. One that's not mentioned on there is what's called an ulcer. An ulcer is basically a break in the skin, much more common in our diabetic patients, and we'll go over that later when we get into diabetes. Next slide, please. So moving to orthopedic conditions. One is that we see a lot of, especially once again as we go through life, plantar fasciitis. Plantar fasciitis is that old, you hear the heel pain. Some people will say the heel spur. It affects the bottom of the foot. A lot of times you'll have pain when you first get up in the morning, or as you're walking, doing your activities, you get a lot of pain in the heel, sometimes going into the arch. Hammer toes. Hammer toes are just toes that contract, no longer are straight. They typically go up in the air, and unfortunately they can rub in shoes and cause a lot of pain. Bunion and bunionette. A bunion is when that big toe goes to the side and then you get that bump on the side of your foot. That's on the big toe side, whereas the bunionette is the same thing on the little toe side. Once again, those can cause pain. They can make it difficult to find shoe gear. And as we age, we're much more prone to develop these just because of poor footwear over our lifetime, injuries, and genetics does play a role also with most of these conditions. Osteoarthritis and bone spurs. Like I said, arthritis can affect any joint in the foot. The big toe joint is a very common one. Of course, the ankle joint is very common. And of course, it can cause a lot of pain for some people. However, other people really don't have much pain, even though they do have arthritis in their joints. And of course, sports medicine related injuries, ankle sprains, those little twists and tweaks that happen all the time, especially when we're working in the yard or doing activities. Next slide. Neurologic conditions. Neurologic conditions, of course, refers to nerves. One common one we get is what's called a neuroma, which is that picture on you're seeing there. A neuroma is just it's a benign growth of the nerve. Commonly, you'll get burning, numbness, tingling, especially of those toes going out from the neuroma. A lot of people will say sometimes it feels like they have something in their shoe when they're walking. Once again, it affects a lot of people as we go through life. You can have a cutaneous nerve entrapment, where a nerve just gets irritated or entrapped. A shoe rubbing on the area or an injury. Neuropathy is something we see a lot more now than we used to. Neuropathy is basically just a basic deterioration of the nerves, and it commonly shows up first in our toes. A lot of people will say, you get pain at night when you're just sitting, in your chair. They can go numb, they can tingle, they can burn. They can just give you strange sensations. Years ago, about all I ever saw with neuropathy was with our diabetic patients. Unfortunately, now we're seeing neuropathy with a lot of patients who don't even have diabetes anymore. And unfortunately, we're not sure why. And you can have what's called idiopathic neuropathy, which just means there's no really known cause for it. It's just occurring in your body. Tarsal tunnel syndrome is another one that happens. That's where a nerve gets trapped going in through what's called the tarsal tunnel area of the foot, similar to carpal tunnel that you can get in your hands. You'll have pain, burning, tingling, everything else going on in the foot. Next slide. Diabetes-related foot and ankle conditions. Unfortunately, diabetes affects a great portion of our population. And one of the areas it does affect the most is the foot. Due to over time, our circulation can diminish due to the diabetes. Our sensation in our feet can diminish due to the diabetes affecting the peripheral nerves in our feet. So this is unfortunately a picture of someone who's lost a toe, probably due to having an infection or something like that in the big toe region. Neurotrophic ulcers, basically a neurotrophic ulcer just means you got a break in the skin or an ulcer due to the fact you couldn't feel. Once again, due to that neuropathy. Unfortunately, also with diabetes, our skin will dry out quicker. Diabetics are more prone to having the onychomycosis or the fungus in their nails. They can have, like I said, that darn neuropathy affects diabetics. So a lot of diabetics can have a lot of burning and tingling and just pains that can wake them up in the middle of the night, or it can make it difficult to sleep. Another diabetes-related foot condition is what's called a Charcot foot. Charcot is basically just a destruction of the joints in the foot. Typically, it's more with our diabetic patients who either undergo an injury or who have a uncontrolled diabetes or something else going on. Next slide. Onychomycosis. Onychomycosis is caused by a dermatophyte or a fungus. It's commonly seen in the skin or the toenails. It's one of those things, a lot of people get it from an injury to the toenail. You can pick it up from anyone, anywhere. Some people are, it's their ability to get the fungus is greater just because of their inherited traits. So some families just naturally can't fight off the fungus as well. It is more treatable than it has been in the past. However, fungus is not easy to get rid of. There are oral medications, there are topical medications. Unfortunately, A lot of them don't work that well. However, there are treatment options. You have to differentiate it from a melanoma, but that's, in rare instances, we do have to take a little biopsy of the area just to make sure it's not a melanoma, or a skin cancer. But onychomycosis is very common and, definitely affects a great portion of the population. Next slide. Treatment, like we talked about, debridement just means we trim the nails way down and thin them up. That makes some nails, number one, feel better, because thick nails can be very painful. You can use topical treatments. There are all sorts of over-the-counter treatments out there. Oral medications, the downfall is they are typically absorbed through the liver. So we do have to do a little blood work while you're on the medication. Usually it's a 3-month treatment. A matrixectomy is just a procedure we do to remove the toenail. We can remove just a corner, we can remove a whole toenail, and make it so the nail should not come back. And that can be done right in the office. And you go about your business and do your routine stuff afterwards. You just have to perform a little home care afterwards. Next slide. Paronychia is just, like I said, a little infection of the nail region. Typically, you'll see some redness, maybe a little puffiness or swelling. Typically, it's due to a wide or incurvated nail plate. So, like I said, the most common reason we see a paronychia is from an ingrown toenail. You may get a little bit of drainage, may have a little pus coming from the area. And the great toenail is the most common area to get a paronychia. Once again, ingrown toenails are more common as we go through, as we age, just because our feet and our toes are everything's constantly changing as we go through life. And our nails do also. And typically, they get stepped on, they get bumped, you kick things, and that can have changed the growth of the nail. So that is more prone to developing ingrown toenails, once again, as we age. Next slide. Treatment. You can do what's called an incision and drainage, is where we just sort of remove the pus out of the area. Oral antibiotics. If you get in soon enough, then typically oral antibiotics are not necessary. A lot of times just some soaking and a topical Neosporin or triple antibiotic are fine. The long-standing infection may require an x-ray. That's pretty rare. That if they are untreated long enough, you can get an infection in the bone. Or you can, like I said, pretty rare. I've only run into that a couple of times over 25 years. Chemical matrixectomy is basically where we remove part of the nail or the entire nail, use a chemical to stop that side of the nail from growing. So that is an option for treatment of these ingrown toenails that are chronic and constantly bother you. Or a lot of patients, we just trim out the side of the toenail, make it feel better, and that way you don't have to worry about it. So unfortunately, ingrown toenails can cause a lot of pain and problems. And as we age, of course, we can't see down there as well, and we can't get down there as well. So it does make it more difficult to take care of them. Next slide. Plantar fasciitis, we had talked about with an orthopedic condition. That's that darn heel pain. It's just an inflammation of the plantar fascia, more common at the bottom of the heel bone or the calcaneus. It does become chronic, in about 5 to 10% of all patients. In other words, it is something that can come and go. However, the vast majority of the times, it's one thing that once we get you calmed down, you're able to live with it forever. It's not necessarily associated with the heel spur, but a heel spur commonly does occur with it. Once we get rid of the pain, we do not worry about the spur. The spur is bone, it'll be there forever. However, a lot of patients actually have a heel spur and have never had a day heel pain in their life. So the spur itself doesn't cause the pain, but the spur lets us know that plantar fascia has really been pulling at that insertion site. And well over 90% resolved with conservative treatments such as what's called a night splint, arch supports, therapy, injections, like just a lot of different ways to resolve heel pain. Next slide. And once again, this just shows that plantar fascia there on the bottom of the heel bone. Typically, you'll have pain upon getting out of bed in the morning. A lot of times after you get on the foot and get in your shoes, the pain gets a little bit better for a while. And then as you're on it more and more, then the pain returns. And poor footwear can play a role in getting plantar fasciitis. So like I said, an arch support or a good supportive shoe can hopefully calm down a lot of plantar fasciitis symptoms. Next slide. Diagnosis, typically it's usually more just with, pain on palpation of the area. Certain foot types like a pes planus or flat foot are more prone to developing plantar fasciitis, but it can occur in any foot type. An x-ray, of course, will let us know if, you do have a spur down there, if there's anything else going on. An ultrasound is a device you can use that actually will measure the thickness of the plantar fascia, which sometimes we do need to do. However, very rarely do we actually go with an ultrasound treatment or diagnostic ultrasound. Next slide. Treatment. Commonly stretching is a good one. Of course, the rest, ice, elevation, always help with plantar fasciitis. Change of shoes, over-the-counter inserts. Like we said, there's a device called a night splint that actually Medicare does cover. Injections, physical therapy. There are all sorts of options to get you feeling better with that darn plantar fasciitis. Next slide. There's the night splints, the orthotics. NSAIDs like ibuprofen. For some people, they do help. I'm not a big fan of NSAIDs for plantar fasciitis. Most patients have already been taking them for a while before they get in to see us. And those darn things can cause some stomach issues and things. So they can help, but it's usually not one of my personal big treatments. Cortisone shots, physical therapy, rarely surgery. We see a lot of plantar fasciitis, and I would say, less than 1% of all patients ever need any type of surgery for this condition. Next slide. Hammertoe. These are just some pictures of some types of hammertoes. A hammertoe is just, like I said, just a contracture of the toe. The PIPJ, which means the proximal interphalangeal joint, your toe has 3 bones. So usually it's that first bone that sticks up in the air, and then the other 2 bones go down a little bit, more like the bottom picture there of that toe next to the big toe. You can have other types of hammertoes where it's just the tip of the toe going down into the ground, which is more of what's called a mallet toe. The downfall of hammertoes is, of course, they can rub and irritate in shoes. And then you can end up, especially with pre-ulcerative areas or actually ulcerations in patients with diabetes, or even, patients without diabetes, from rubbing in shoes. Really, the only treatments for hammertoes are staying in good shoes, padding, or you can surgically correct a hammertoe. Next slide. Debridement, of course, is basically just cutting away the callus or corn that can develop. Some hammertoes will get calluses or corns on them. A lot of them will not. Padding can help. Sometimes it's hard to keep a pad on the toe. Shoe gear change, definitely a simple thing to try. Or you can try, surgical corrections. Sometimes you can do more of a minimally invasive procedure right in the office, where we release a tendon to help lift up a toe. Unfortunately, other hammertoes require a more of a hospital-based procedure to straighten them out. Next slide. Hallux valgus is that darn bunion. Basically, it's a painful bump. What happens is that first metatarsal bone there on the bottom, the one with the big toe, starts to go out, and then the big toe goes over, and then we get that bump on the side of our foot. Of course, it can cause pain in shoes. Some people will have these big old bunions and never have a day of pain. Other patients can have a very mild pain or bunion and end up with a lot of pain. Of course, wider shoes can help. Sometimes an orthotic device, which is an insert in your shoes, can help slow or stop the pain. Unfortunately, the only true way to get rid of a bunion is to go in and surgically fix it. But bunion or surgery is definitely not always required for bunions. I have a lot of patients who have lived with bunions for 40 or 50 years and they're still out there golfing and doing what they want to do with no problem. So you can definitely live with a bunion. However, if it's hurting and stopping you from doing what you want to do, you can go in and surgically fix it in a hospital-based surgery. Next slide. Osteoarthritis, just that darn arthritis. We commonly see it at the big toe joint. You can see on this x-ray of that big toe joint, the joint space between the big toe and the metatarsal bone there diminishes. So those bones get closer together. And then you start seeing a little bit of bony buildup around the sides of the area. And as those bones get closer, well, then they start to rub and we lose that cartilage. And that's when we end up, getting a lot of pain from the area. Next slide. Treatments, you can try injections, physical therapy. Once again, you can do NSAIDs or anti-inflammatories. You can even use a topical anti-inflammatory. Voltaren gel just went over the counter last year. And that's a good over-the-counter anti-inflammatory gel that you can just massage into the area. Orthotics or shoe inserts can take pressure off the joints. And of course, surgery is an option too for arthritis that doesn't respond to the conservative treatments. Next slide. An ankle foot orthosis, or different types of bracing and things can really make a difference for the right people. An ankle foot orthosis basically just means you have a device that is taking care of the foot and as well as the ankle. They do have some over-the-counter devices. Of course, some patients will require one that's custom made for you. And that's something that most insurances will cover for you to get a device for certain foot conditions. Next slide. These are just another type of an ankle foot orthosis. This one is just more for really severe arthritic changes or something where we don't really want the joint to move much, whereas the previous one allows a lot more motion for different conditions. Next slide. Ankle sprains is just basically a tearing or stretching of the ligaments of the ankle. Usually it's the ones on the outside of the ankle. That's by far the most common type of sprain we get. Unfortunately, once again, after we've sprained our ankles a few times, so as we go through life, sometimes the ankle can become more unstable due to the ligaments just deteriorating due to the previous sprains. Most often, conservative treatment, physical therapy, those darn walker boots if it's pretty sore, braces, that type of thing. Surgical repair, of course, they can be surgically repaired if needed, but you always want to try, of course, the conservative treatments. Next slide. Morton's neuroma is just that growth of the nerve we talked about. It's just a swelling of that nerve, most commonly seen in that third inner web space, which goes out to the third toe and the fourth toe. But you can feel numbness, shooting pains, tingling, and it can cause a lot of pain and problems. Go ahead, next slide. Differential diagnosis, in other words, things that can appear to be a neuroma, but of course it isn't, is a stress fracture, a callus, a Freiberg's infarction fraction is just a loss of blood flow to a bone that causes pain in the area and some arthritis. Capsulitis is also a common thing we see as we age. Capsulitis is just some inflammation of the capsular tissue. So a lot of people get that pain in the ball of the foot. And you'll find, you don't want to be barefoot. Even in shoes, you have pain in the ball of the foot. Capsulitis is very common with our older population because the cushioning is gone. And that is something we definitely see a lot of that in the office. Bone tumors are definitely less common. We really don't see a whole lot of those in the foot thank goodness, at this point. Next slide. Treatment for a neuroma. We try change of shoe gears, paddings, once again, an orthotic device or cortisone injection. Rarely surgical excision is needed where we actually go in and remove the nerve. But that is something that does happen for some patients. Next slide. Diabetic neuropathy we talked about. Diabetes, peripheral neuropathy basically is the deterioration of the nerves most commonly seen in our diabetic patients. Like we talked about, numbness, burning, tingling, shooting pain, sensitivity to hot and cold. Unfortunately, when we lose feeling in our feet, we're much more, we don't have our balance as well. We're not as stable. And those are all things that, can occur with neuropathy. Neuropathy symptoms are typically first seen in the evening, much more common at night and usually worse at night. And like I said, a lot of patients will actually get woken up in the middle of the night with diabetic neuropathy pains. Next slide. Many causes of neuropathy, diabetes is the number one. Chemotherapy can cause it. And like I said, unidentified sources, we're seeing more and more of that idiopathic neuropathy. Risks or falls, driving becomes difficult because you can't feel as well. Of course, pain is the big one we see. There's no cure for neuropathy. Topical medications can help. Oral medications can help. Sometimes injections can help also. Unfortunately, there's a lot of things you'll see saying, oh, this is the newest treatment for neuropathy. It'll cure you. It'll do wonderful things. Unfortunately, a lot of those are a waste of your time and money because as of now, there's definitely no known cure. Next slide. Diabetic ulcer we talked about is basically a break in the skin. Usually it's a bony prominence is involved or like a hammer toe or underneath a metatarsal head or on the bottom of our foot. Often it starts as a blister, a corner, a callus. Next slide. Unfortunately, these things can become infected and cause other issues. So treatment is we debride the wound and we want to remove all that hard, bad callus off the area. And then we clean it up and try to offload the area. There are a lot of wound care products available to treat diabetic ulcers. Next slide. Diabetic therapeutic shoes. Medicare will cover 1 pair of shoes and 3 pairs of inserts only for our diabetic patients with certain factors. We do diabetic shoes in the office. They are a wonderful thing. The reason being, they come in a lot more widths and sizes. So we're able to accommodate a lot of those hammer toes and bunions and everything else with the diabetic shoe. And according to Medicare, 50% of amputations were preventable. And diabetic shoes are the main reason. Medicare has covered diabetic shoes due to that fact that they do help prevent amputations by getting a person in the right fitting shoe and a shoe that doesn't cause a problem. Next slide. Recommendations. These are just some basic things for aging feet especially. Number one is check your feet daily. Look for sore spots, look for little red areas, inflamed areas. If you can't do it, have someone, take a look. A mirror can help see the bottom of your foot. Unfortunately, as everyone knows here, as we age, it gets harder to see down there. It gets harder to get down there. So we can have a lot going on with our foot and not realize it. So it's important to check them out daily to spot something before it becomes a big problem. Number 2, of course, is staying active. Range of motion, move those toes, move those feet, do some stretching. when you're sitting in a chair, just go through a range of motion, move them up and down, go around in circles. We want to keep the motion in our toes and our feet and our ankles. The old thing, if you don't use it, you're going to lose it. Wear good shoes, including indoors. Barefoot, like I said, becomes less and less comfortable as we age. So get into a good fitting shoe that gives you good support and good cushion. Moisturize your skin. Make sure and dry really well in between your toes. When you do moisturize, you want to go everywhere except in between the toes. You don't need to put lotion in between your toes typically because it stays moist enough as it is. But it is important to keep that skin nice and moisturized. Like I said, as we age, our skin dries out easier. It's more prone to cracking and then causing problems with that. And of course, if you have anything going on, see your primary doctor, see your podiatrist, get in to see someone. Because like I said, the key is to prevent anything from becoming a big problem. Next slide. And that's it.
Okay. Wow. Well, as I suspected, we have some questions for you, Doctor. So Kathleen, there you go. Thank you. I'm going to start at the top of the list, everybody. There aren't actually that many. Okay. Do you know some easy things to do when you have a plantar fasciitis flare-up?
Icing every day helps. Icing for about 20 minutes, a couple of times a day can help. Stretching out your calf muscle, stretching out the bottom of your foot. You can freeze a little water bottle and gently roll that back and forth for about 5 minutes. That way you're getting a little icing, a little bit of stretching as well. You can roll a little tennis ball underneath your foot to help stretch it out. Staying in shoes, especially like a good athletic shoe. From the time you get up till the time you go to bed, be in a good supportive shoe, trying an over-the-counter arch support, something to give a little bit more support to it. But ice, stretching, and a good support are your best first line things to go with.
Yeah. I had a friend that used a rolling pin once for that, but I like
something similar. Yeah.
I like your idea of the
stretch it out.
Yeah, but the chilled water bottle, that's smart.
Frozen water
That's
bottle
really
works
smart.
well.
Yeah. Okay. Next one. Oh, this is just a compliment. Thanks so much for mentioning misinformation regarding cures. She's a librarian, so she appreciates the fact checking there.
Yeah, there's a lot of things out there, especially about neuropathy, because it can be so hard to treat, and patients get so you just want something to work, and you'll see these things, and next thing you know, you spent a lot of money on something that felt great while they were doing it, but 2 days later, you're back to where you were and you're just out a whole lot of money. So you definitely need to be careful with some of those things.
Yeah, good. Okay, what is the treatment for capsulitis?
Capsulitis, number one, once again, is we try to offload the area or put a little pad in your shoe. So once again, a simple thing is an arch support type device. Icing is really important. One thing you can do is freeze like a little styrofoam cup. And then you have a little handle on like a little handle on your ice. And then you can just gently roll it right along that area for about 5 to 6 minutes, a couple of times a day. And trying that Voltaren gel, that over-the-counter anti-inflammatory gel, can make a difference also. But once again, you want to avoid barefoot as much as you can with that capsulitis and stay in a good cushion supportive shoe.
Okay, thank you. Okay, here's one. How about a tingling like a cell phone ringing next to the outer foot? I get it, especially late evening, and can't make it stop. I don't have any other conditions like diabetes. Could it be gout?
Probably not gout. Gout's typically more, redness, swelling, hot, pain. That typically, what this person is describing sounds more like a neuropathy type of a situation. Like I said, tingling, burning, shooting pain, strange sensations, typically worse in the evening. those are usually more of a neuropathy type of thing. And like I mentioned, unfortunately, we're seeing more and more neuropathy without other disease process or anything else. It's a neuropathy of unknown origin.
Mm-hmm. Did you talk about a way to slow that down? Can you slow that
There
down?
are actually over-the-counter capsation is a topical cream you can use called capsation or Zostrix.
I've heard of that, yeah.
Those can help for some people. Some people actually use topical CBD and have had good luck with that. There is a prescription medication pill we use a lot called gabapentin or Lyrica. Are oral medications that can make a big difference for people. Yep.
Okay. And what is your opinion on reflexology?
I've had some patients have really good luck with reflexology. If it helps, hey, I think it's wonderful. Just like everything else, unfortunately, I've had patients who have tried reflexology for other things and haven't had good results, but I've definitely seen some patients have good results with it. So it's definitely, we shouldn't cause, it's not going to cause any problems. And, same with, acupuncture and all those, other treatments for the right person, they definitely have a role.
Okay. Any tips for preventing and removing calluses that result from regular distance walking?
Keep them soft. There's a cream or an ointment called Flexitol that can make a difference to help really soften up the area. They have those little pumice stones. I'm not a big fan of the corn and callus remover pads with the acid on them because acid can't tell the difference between callus and good skin. And unfortunately, we see a lot of patients who burn away too much skin and end up getting an infection or a wound from those acid patches. So not a big fan of those, especially in our older population where our skin gets a little bit thinner. So yeah, softening. And once again, trying to offload the area, a little pad behind it or around it to try to keep it down.
Okay, I think we've dealt with this one, but I'm going to ask it anyway, just for repetition's sake. Is there a better med than gabapentin for neuropathy? Anything on the horizon?
As far as right now, there's really nothing. I mean, Lyrica came out, I don't know, 15 years ago, maybe. That's been the newest oral medicine for neuropathy. There is a new topical treatment that it's approved, but it's not covered well by insurance yet. So we're still in the process of trying to get that more covered for our patients. But hopefully in the next year that will be more mainstream. It's an application you do in the office about every 3 months. So it's a topical thing you put on. But right now we're not getting it approved, unfortunately, through insurance.
Okay. Let's see. Yeah, I've read this too. I was told that spending some time barefoot was healthier for feet. Not so? Probably depends on the age, I'm guessing.
Depends on the age, yeah. If we start out barefoot and are barefoot, from day one, well, then your feet will adapt and do everything else. Well, our society, we've, started out in shoes and everything else. So as we get later in life, like I said, you need more support and typically more cushion. So, shoes are definitely better for you. So yeah, I'm not barefoot is fine a little bit, but you don't want to overdo it. Especially, like I said, as we get older.
So this one sort of differentiates between sudden foot cramps and sudden pain. Are sudden foot cramps in the middle of the night necessarily the start of neuropathy?
No, not necessarily. No. Foot cramps can be caused by, well, you unfortunately, some people do get foot cramps, and there are different medications for that. Foot cramps, leg cramps. There are a lot of times we're not sure what does cause them. Sometimes it can just be used, from overuse, or the wrong activity can cause your foot to cramp up at night. But there are, some people naturally will get cramping at night, and there are different medication options for that. More pills, unfortunately.
Right.
Stretching can make a big difference. Stretch before you go to bed, stretch out those muscles down in the foot and legs. And a lot of times that can help diminish the cramping at night.
Do you ever recommend magnesium glycinate?
Magnesium can help,
Uh-huh.
for neuropathy, one other thing is the B vitamins, B6, B12. Some people find, that can help with some nerve pain and neuropathy pain. So some patients will actually get B injections from their primary docs, their family practice docs, for neuropathy. Sometimes that can help.
Okay. And what is your opinion on IV antibiotics to treat foot wounds versus pill form when the patient has poor circulation?
Boy, that's a good question. The downfall of with poor circulation, we need to get the antibiotic to the area to do the best thing. With circulation impairment, it can be a little bit more difficult to get that in there. Typically an IV treatment is the best, best option to get the infection under control. That's something a lot of times, depending on where the wound is, how bad the circulation is, and other factors, going that way. But that's why infectious disease definitely are the people, we usually go with, any type of, IV antibiotics or anything else. At least in our practice, we refer to the infectious disease specialists to deal with those antibiotics.
Okay. How is a swollen ankle treated? And does it depend on the cause, maybe? I don't know.
It depends on the cause greatly. Yeah. Unfortunately, once again, swelling is another thing that happens a lot as we age. Elevation is very important. Just getting the feet up in the air. Sitting with your feet down all day long is not good. Compression socks can make a big difference for a lot of people. You don't necessarily need the big old heavy ones that, everyone thinks about. You can try some over-the-counter compression socks that you can get at, Walgreens or Walmart or any store. And for some people, that's all they need. It'll control the fluid, prevent it from getting down, and it can make a big difference, making you more comfortable.
Okay.
But elevation is very important.
Okay, thank you. Let's see, where am I? Would you share the name of the topical treatment for neuropathy?
Capsation.
Oh yeah, capsation.
Yep. Capsation, or it's I'll call Zostrix is another brand. Zostrix, I believe.
Okay. And again, we are recording this, so you can watch it again in a couple days if you need a refresher course already, like I normally do. Let's see now. Can you recommend specific exercises to keep our feet healthy? You mentioned stretching.
Stretching is definitely important, especially stretching out our calf muscle and our Achilles tendon. Just bringing your foot back and holding it, when you're sitting, holding it for a few seconds, just going up and down, around in circles. A simple thing you can try is just to try to go through the alphabet with your foot. Try to make an A, try to make a B. You're going to stretch every muscle, tendon, and ligament trying to go through the alphabet. So that's something simple you can do. But it's really important to stretch out your calf and your Achilles by doing like a wall stretch. And if you go online, you'll see, all sorts of good demonstrations of that. But that's one big one that's important, is stretching out your calf and your Achilles.
Okay. Anything to do for painful ankles on the top? It really hurts when I walk and aches at other times. So just the top, maybe at that joint where the.
Right.
Yeah.
Well, once again, greatly depends on what, that could be, from arthritis. It could be from swelling. It could be from a nerve getting irritated. It could be some tendonitis from the tendons on the front part of our foot and ankle. Sometimes a compression sleeve can help. Those little foot and ankle little things just slide on, just to give a little more support and stability, can help. Once again, a topical medication, ice is always something, simple to try if it's sore at the end of the day.
Mm-hmm. Okay. And what's your opinion on vibration plates for people for circulation?
If you can, massage, other things can help to increase the blood flow to the area. So, if you're able to, work those muscles and tendons a little bit, it may definitely hopefully help make a little difference. But I don't know, in any type of severe issue, it's really not going to make a difference. If you're not getting the blood flow down there with the artery, or, if it's not wide enough to get the circulation down, unfortunately, you can vibrate all you want and you're just not going to get enough blood flow to make a difference.
Okay, I think this might be our last question. Does Medicare cover a visit to your office even if no major concern shows up?
Yes, you can, we can definitely do a foot exam, and just go over everything and see, what's going on, and give you some, just basically a general, foot exam. Medicare does not require a referral or anything like that for a podiatrist. And then, general root or nail care, a lot of patients will be able to get in for, onychomycosis or other things, and definitely have them looked at and taken care of. So, Medicare definitely would take care of that. And overall, Medicare does a good job with podiatry, I think. We don't have any issues with Medicare. They always seem to do pretty well for us.
Okay. All right. I've got one question since
Yes.
we've got 3 minutes left. And I'm going to bring it up just because it's news to me and I wanted you to comment on it. I just learned there's a thing called big toe arthritis.
Yes.
And I think I have it. I just occasionally have just a pain just in the joint of the one big toe. And can you speak to that? Is it common? Is it
it is fairly
harbinger
common.
of
Yes.
horrible things to come?
Arthritis in the big toe joint, it's fairly common. For some people, it can be greatly painful. It's one of those things that it typically just slowly develops over time. And then it reaches that point where all of a sudden, now it's hurting and causing you a lot of problems. The movement of the toe it doesn't move as well as it used to. Sometimes you may get a little grinding or, a little popping in the area. It can be very painful. You can, once again, try topical, anti-inflammatories on the area. Offloading it with an arch support type device to take pressure off the joint can help. Staying in good shoes. But yeah, like the one slide mentioned, you can do injections, you can do, other things for that. And in rare instances, surgery is required to get you back pain free so you can get out there and, do what you want to do.
Sure. Okay. We have another last minute question. Is there anything you can do to prevent hammertoe?
Staying in good shoes is the best thing. Avoid those pointy-toed heels. Unfortunately, a lot of times we're too late. The damage was done years ago, and the toe is just going to start to deteriorate and hammer up. Also, genetics plays a big role with hammer toes. Some feet are just more prone to developing the hammer toe. So certain foot types, no matter what you do, you're going to end up with hammer toes.
And a good shoe, what is a good shoe? And is it a case of you get what you pay for? Because I found that sort of to be true.
In a way, yes and no. We don't, if you're not, you don't need to go out and pay for the top of the line running shoe and all that type of thing, because we're not most people aren't going out there running those high miles or anything like that. You want something that gives good room in the toe box, gives you good support and good cushioning. So yeah, you do need to, you have to pay a little bit for it. But the main thing is, trying on different ones and different styles, and it should feel good the minute you put it on. Shoes don't break in like they did years ago. If it doesn't feel good the minute you put it on, it's not going to feel better in a week. So, don't convince yourself you like the way it looks, so it's going to feel better. It's not.
Yeah, so that whole breaking in thing is a myth. Don't worry, you'll break them
for
in.
the most part anymore. Yeah.
Wish I'd known that when I was 20.
Yeah. Years ago, shoes were constructed a little bit differently. And yeah, there was a little bit more of a break in, but most shoes anymore, if it's not feeling good the minute you put it on, don't bother. It's not going to get better for you.
Okay, can I squeeze one more in? Because I'm fascinated by this
Sure.
question. Will we ever be able to manufacture collagen?
Once again, they're definitely working on it. They are, and they have some synthetic type of collagens that we are working on, and they're actually doing some things with like neonatal type tissue, where we're able to actually have some of our wound products do have a collagen basis to them. So it's sort of laying down a precursor to the skin to help heal up a wound faster. So it's getting, wound care has come a long way. Unfortunately, it affects a lot of our diabetic patients. So there's a lot of research done with that. But yeah, they're definitely making progress with collagen.
Yeah. Okay. That's it. Good questions, everybody. Thank you. And thank you, doctor. That was very informative. I learned a lot of new information, including the word bunionette. That is adorable. I know it's painful, but that's the cutest word I've heard, to make a bad situation better. Bunionette. Use it in your vocabulary tomorrow. All right.
Great.
Thanks very much, everybody.
Thank you very much.
Thank you.
We will see you next time.
All right. Thank you.
Uh-huh.